Joining me today to clear up some of the confusion around hormone therapy is Dr. Margaret Nachtigall, reproductive endocrinologist and women's health expert and menopause expert from NYU Langone Health. And she's also the co-founder of the North American Menopause Society. So welcome back to GRUFFtalk, Dr. Margaret. You're a frequent visitor.
Hi, so nice to see you today.
We have a lot to talk
We
about.
do.
Some of the really important medical associations have recently come out with revised position statements around hormone therapy, which kind of has put hormone therapy back into the news again. So we really want to hear about those position changes and anything else that you can update us on regarding hormone therapy. So what's up?
Great. I really wanted to talk to you because I really think that there's some confusing information out there, and I'm hoping that after our conversation today, some of these things will be clarified because it's so important to get clarity. It's also my main point is that really for hormone therapy, trying to figure out whether it's right for you or right for someone else, it's an individual decision. And there are so many factors at play that it's often very difficult to decide. So I'm hoping that we can have a conversation, bring up some important parts, and then people can talk to their doctors and get some ideas and see if it's right for them. So I want to start with just what you mentioned, the position statement. So the first one is the 2022 hormone therapy position from the North American Menopause Society. And that just came out in July of 2022. And one of the main points, the bullet points, and I'm going to read here, so I'm going to look at my screen, which is that for women aged 60 years and below or are within 10 years of menopause onset and have no contraindications, the benefit risk ratio is favorable for hormone treatment for bothersome vasomotor symptoms and for prevention of bone loss. So what they're saying is that anyone who is within 10 years of menopause that's under the age of 60, so if they haven't had estrogen in uh, that amount of time, that it makes sense, if unless they have a contraindication, to be on for symptoms. But then the United States Preventive Service Task Force 2023 came out with their statement, and their statement said basically the opposite. They said that based on the review of evidence, the task force recommended against the use of hormone therapy, either estrogen alone or in combination with progesterone, to prevent chronic health problems for people going through or who have gone through menopause. So now we're confused, right? Then
Absolutely.
another organization, and these are all very large, very trusted organizations. I trust both of them. And now another one that I also really, really trust is the American Heart Association. Their scientific statement came out, and they came out with a number of different recommendations. But at the very bottom, the statement read that menopausal hormone therapy initiated in women younger than age 60 or within 10 years of menopause to alleviate menopausal symptoms and to prevent and treat osteoporosis is currently the sole intervention that decreases the risk of cardiovascular disease and diabetes in healthy women at midlife. So now another organization is saying, in order to prevent heart disease and diabetes, you should go on hormone therapy. So I think what we need to do is tease it apart and figure out what's the data, what do we know, and how am I going to use this to make a healthy choice for myself. So the key here is for yourself. The key here is to weigh the risks and the benefits for each person and decide if it's right for you. So let's talk about what are the risks and what are the benefits.
Right.
So the benefits are that, and we're going to talk about estrogen because estrogen is the hormone that helps all of these symptoms and that we're talking about. The only reason we add progesterone in there is for those individuals that do have a uterus. The progesterone is used to stabilize the endometrium, which is the lining of the uterus, to prevent endometrial cancer. So if an individual does not have a uterus, they do not need progesterone, which actually simplifies a lot of hormone therapy. So if you've had a hysterectomy, there are now some benefits to having gone through that surgery. Okay, so what are the benefits of hormone therapy? What are the benefits of estrogen? Big benefit is decrease in hot flushes. That's huge. A decrease in loss of memory. In other words, keeping your memory. Probably some advantage to prevention in terms of Alzheimer's, and we'll talk more about that. A improvement in the vagina, an improvement in insulin sensitivity, less diabetes, less skin wrinkling. That actually I could really use. Sleeping better.
Same here.
Estrogen helps sleep. A decrease in colon cancer, protection of the bones, and improvement in bone density, which I know you appreciate tremendously.
So, and you know, I've said this many, many times during our prior conversations. It's a regret that I did not consider HT.
Helping so many people,
yes,
so that they can make this decision if that's right for them.
Correct.
So an improvement in decreased hot flushes, good for the bones, good for the vagina, good for your memory, decreasing depression, so increasing, better for mood. All of these are the benefits that we talk about for hormone therapy. And then what are the contraindications? Well, anyone that has an estrogen receptor positive tumor, whether it's a breast tumor or another kind of tumor, if they're estrogen receptor positive, they should not be taking estrogen. So those people can't take it. People that have a high probability of having a blood clot, so if they've had a previous pulmonary embolus or a previous blood clot, those are people that I usually don't start on hormone therapy. Someone that has irregular bleeding and we don't know why, we can't figure it out, that's someone that has what's called a relative contraindication, meaning they may not be able to take it, but we'll see, because sometimes we can figure out the cause and then they can go on it. But people that fall into those categories of either estrogen receptor tumors, chronic liver disease, or high likelihood of blood clotting. For instance, someone that has a genetic predisposition or a genetic factor that makes them more likely to have blood clots, like a factor V Leiden deficiency, they cannot be on it. So if you don't have those contraindications and you want to have those benefits, then estrogen is something that you might want to think about. And if we're going to do hormone therapy, there are lots of different ways to do it. We can go on a patch, a pill, a foam, a gel, or a vaginal option. So there are lots of different ways. And what's interesting is each one of those different ways, they contain different types of formulas. So there are synthetic formulas of estrogen, there are natural forms of estrogen, there's estradiol. So there's different ways. If you're going to go on estrogen and you have a uterus, remember we need some form of progesterone. Now I'm going to talk a little bit about the WHI, the Women's Health Initiative that was done that had 100,000 women, and we have a lot of information about that. But before I mention that type of progesterone that we used was a synthetic progesterone, majoxyprogesterone. And that one, as I'll show you, has been linked to an increase in some breast cancer. So now when we are talking about adding progesterone, we usually use progesterones from other sources, either a progesterone containing IUD or a natural progesterone, a micronized progesterone, which is another option for individuals. There's another medication that had been taken off the market that's coming back that has an anti-estrogen in it. So you don't even need a progesterone called basodoxifene. So that may be back. So anyway, we want to individualize, one, whether or not you take estrogen. And then if you are taking estrogen, how do you take it? What dose are you going to use? And what is going to be your delivery system? All of those things are going to come into consideration.
I'm curious about the delivery systems. Is there one that has proven to be more effective than the other? Or is that really also very individualized? And
so individual. The one thing I would mention that sort of applies to many, many people is if it's transdermal through the skin, so whether it's a gel or a patch, if it's through the skin, it's less likely to cause any kind of blood clotting. If it's given by mouth, it has an increase in blood clotting. So if someone is particularly prone to blood clotting, but not enough to be contraindicated, then that's someone that I would stay away from a pill.
Mm-hmm.
And then a lot of it is patient choice. Some people don't like wearing a patch or they're allergic to it, and some people would much prefer to take a tablet. And the flip is often true as well.
Right.
Another thing with the patch is that because it's a slow release over time, is that you can have very even doses as opposed to a pill where it's one dose that takes a little while to start working and then may wear out by the end of the day. So that's another
Interesting.
reason why some people like the transdermal approach.
Mm-hmm.
So we talked a little bit about the WHI, the Women's Health Initiative, with 27,000 women that were in an age group that ranged from 50 to 79 years old. But the age group that I'm going to focus on is the 50 to 60-year-olds, is the people who went through menopause recently, not those that are a long time from menopause. Because if you're a long time from menopause, then starting estrogen usually has a negative effect and on the heart and on the brain. And so that's something we don't typically talk about. But when we look at the WHI, that looked at a lot of different features. When we break it down now, 20 years later, and this was done really nicely, there's a description of it in that 2022 menopause position statement. But after 20 years, they came out and broke down the statistics, the data from that study into those people that were taking estrogen alone versus those people that were taking estrogen plus progesterone. And when you look at those that are in the early phase where they're just starting to take estrogen, 50 to 60 years old, and we break it down by category, when you look at every category that I'm going to mention, estrogen alone actually had a benefit. So less diabetes, significantly less death from any cause, lower fractures overall, lower hip fractures. All cancers actually had a decrease. Colorectal cancer was slightly decreased, as was breast cancer, slightly decreased. Interesting, right?
Decrease.
Coronary heart disease decreased with estrogen use. Now, pulmonary emboli and deep vein thrombosis were slightly elevated. They did not reach statistical significance, but they were increased. And this was on conjugated estrogen by mouth. Now, when we look at the data for estrogen plus progesterone, here the same thing was not true. We did see a decrease in diabetes. We did see a decrease in death. We did see a decrease in cancers. I should say because I had nothing to do with it, but I'm watching it. That decrease in cancer, but there was a slight increase in breast cancer after 5 years of use, in stroke, in heart disease, and in pulmonary emboli, but it didn't reach statistical significance.
Right.
So the estrogen alone was benefit. When you added that particular type of progesterone, it did negate a lot of the positives. So I usually tell people not to use that type of progesterone, to use a different kind, and to use the lowest dose that we can to attain our goal, which is to keep the endometrium from developing endometrial cancer. And we now have 20 years of follow-up showing that estrogen is not going to take a normal cell and turn it into a breast cancer cell. But if you do have a breast cancer there and you add estrogen, if it has estrogen receptors on it, it will make it grow bigger faster than without estrogen alone. So that's important. And then what I wanted to talk a little bit about is just if people are having symptoms, estrogen does a great job. So no matter what dose or delivery system you use, you have hot flushes, you take estrogen, it makes them get better. But there are other options. This is not the only option. Today we're talking about hormone therapy, but maybe on another day, we'll talk about some newer medications that have just come out or just finishing phase 3 trials, ability to get rid of hot flushes without estrogen. These are really interesting options.
Really interesting. I've been reading about it in some of the medical journals that I get, I have access to, and I'm really eager to have that conversation with you, actually. One thing I
Right.
just want to point out that you and I had done an episode a few months back, and I'll add a link to it in the show notes, where we focused on the connection of, menopause and estrogen and NHT and heart disease.
Mhm.
And it showed there were many studies that showed that hot flashes could actually contribute to
Yes.
some heart issues. So
Right.
therefore, when you're thinking, oh
Yes.
yeah, well, hot
Yes.
flashes are temporary and they'll pass. Sure. I mean, they're
Right.
uncomfortable, especially
Right.
those who have severe
Right.
hot flashes and frequent hot flashes. But it turns out that hot flashes could be more than
Could be
just a hot
detrimental.
flash.
And it makes sense because when I look at blood flow in the brain as done when individuals have volunteered for studies,
Hmm.
and you look at the blood flow in the brain during a hot flush, unbelievable decrease in blood flow during that hot flush. So it makes sense that they're going to have some changes. So you're absolutely right. So treating the hot flush is not only symptom relief and making the individual feel better, but actually may be protective for heart disease, protective for cognitive changes down the road. And
Right.
so these newer medications, which are going to focus on these things called candy neurons, which are neurons in the brain, which seem to control the temperature system in our body. And now there are some medications that are going to be changing those cells or those neurons and be able to alleviate a hot flush without estrogen. So those are coming down the pike. We'll have a whole section just on that. But with estrogen, people sleep better, their mood is better, their memory is better. But one thing that a lot of people ask me is, yes, it may be better at the time, but what's this going to do to me in the long run? And if you look at the package insert of estrogen, even vaginal estrogen, there's some statement that says this may cause dementia because some studies show that estrogen increases dementia, but other studies show that estrogen decreases dementia. So I'm going to try to help explain why that is and what the thinking is right now. Because there are 50 million people right now who study from dementia worldwide. So it's a huge group of people.
Yes, it's a
This
big
is
issue.
only expected to go up as people are fortunately living longer. Also, women are um, click this. Women are disproportionately affected. So about 55% higher risk per age than men, which is very interesting. And loss of estrogen has, been thought that this must be a contributing factor. So with these controversial findings, what can we say and what do we know? Well, one thing we know is that without estrogen, you look at people, excuse me, and you do this test, which looks at your um, uh, mild clinical impairment. It's a study that looks at how good your memory is, basically. And when they did these on individuals who were starting estrogen treatment, they saw that after 2 years of use, the clinical impairment decreased tremendously after only 2 years. And
Incredible.
if they stopped, you actually maintained that for a period of time. We also see that if you look at dendrites, which are those cells in the brain, on estrogen and off estrogen, if you look in animal studies, you can see that they actually have a difference of appearance, that they look more vibrant. And the other thing that we've learned is that tau protein, which is involved in the development of Alzheimer's, has been shown when tau gets tangled and gets in all these clusters, that is one of the causes for Alzheimer's. And and that's been known for a very, very long time.
Hmm.
But new research has shown that estrogen can actually prevent the tau tangling. They can actually prevent the tau from getting all tangled. So you can imagine that if you can prevent the tangles, you can prevent the Alzheimer's. And it's probably the same timing issue that we know about for heart disease. So if you can prevent those tangles early, great. But if you can't, you won't be able to prevent the disease. And I think it's about that timing that explains why some studies show estrogen being beneficial for prevention of Alzheimer's and others don't. Because if the study was done where estrogen was started early, as close to the timing of menopause as possible, you're going to see that decrease in Alzheimer's. But if you look at the studies where estrogen was initiated later, after 10 years of menopause, then it actually has a detrimental effect. So the answer is, if you're going to start within the window. They say within 10 years, I would say even within 5 years. And so that explains why this controversy really exists. And the same thing is really true on the heart. When you take individuals, exact same age, you take a population of patients, they're all, say, 45, or they're all 55, and you divide them, those that are menopausal compared with those that are not menopausal. The group that is menopausal has a higher incidence of cardiovascular disease than the non-menopausal group. So that right there speaks to the fact that estrogen must be doing something. And now we know from a lot of studies that the timing is the key thing. That if you initiate estrogen early on a very clean blood vessel, a blood vessel that has no plaque on it at all, you're going to help that blood vessel prevent cardiovascular disease. But if you have a blood vessel that already has plaque and then you add estrogen, you actually may cause more plaque.
So let me just clarify that. So when you say start early, you mean within that 5-year window?
I do. I mean that 5-year window.
Okay.
I mean, honestly, the evidence now says up to 10 years, but I just personally, with no data behind me whatsoever, say, it just makes sense to me. But, there is a test, a CAT scan that you can get called the calcium score, which can give you an idea of what your blood vessels are doing and how much plaque may be there. So if there's very, very, very little plaque, I might be more likely to start estrogen, even if you're 7 years from menopause or 10 years from menopause. But if there is plaque already, I'll be very reluctant. Another clue is you can get your cholesterol done. And if you have a very favorable looking appearance of your cholesterol, then that you probably have less plaque than in someone that has a higher cholesterol.
I'm curious about this. Do you personally ask all of your patients if they're planning on taking HT in some form to get that test so that you know?
No, I don't ask everyone. If they are within a narrow window,
okay,
5 years of menopause,
okay,
and their cholesterol levels are good, then I don't.
Then you don't. So it's really for those who are past that and might be showing some other.
Right. Or they have other risk factors for having plaque, high cholesterol, and then I will ask them to talk to their internist and ask their internist if they would like, if they think it would be beneficial for them to get a calcium score.
Okay.
And so that was factor. And there are, other factors such as insulin resistance. We know that estrogen has a beneficial effect on insulin and lowering insulin levels and in decreasing diabetes. And that can be a risk factor. The increase in diabetes or increase in weight or increase in insulin resistance alone can be a risk factor for heart disease.
Yes.
So reversing those factors can also help decrease heart disease. That's a whole, we also did a talk on that, which was decreasing that middle adipose tissue.
Yes. In fact, I think I'm going to add links for that one too. And also the one that we did about menopause and HT in the brain. So I'm going to add all those links in because even if the listeners listening now did hear those, it's never a bad idea. And it's a very good idea to get a little refresher.
So, and then there's a really interesting link that estrogen has been shown to lower something called PCSK9, which is by doing that, it actually helps the lipids. It actually helps lower cholesterol. So that's another way that estrogen may be beneficial for decreasing heart disease. So basically what I just described was this timing hypothesis, which is that if you start estrogen, you really have a window. And so one of the main, points that I have about deciding for yourself if it's right or not is really when you become menopausal, is thinking about this for you or for, whoever you're talking about, so that you can make that decision before that 5 to 10 years go by. It just so happens that those are the same time when you have the symptoms, usually the flushes and the memory loss and the difficulty sleeping and the depression, that all seems to come on right away, right when estrogen levels are plummeting. So it makes sense that this would be the perfect time to go back on.
That does make sense to me. I mean, most women do start to experience those things even in perimenopause, right before that day when they actually become postmenopausal. And so I'm sure, don't you find that the majority of your patients are early adapters of HT, are starting earlier?
It depends.
Most
I see both.
Okay.
I have a lot of patients coming because they're very, very, very symptomatic and they want estrogen now. And then I have some others that have actually been suffering with hot flushes and mood changes and difficulty
for years, right?
For years and years and years. And no one said take estrogen. Or sometimes people say to them, don't take estrogen.
Right.
Or friends will tell them, don't take estrogen. I'm afraid you're going to get breast cancer.
Right.
Don't take estrogen. Don't take estrogen. Don't take estrogen. And then you're in this situation where now you can't take estrogen. So I think it's a good idea to and I don't think estrogen is right for everyone. I really don't. I just think that there are some people where it is right for. And I want those people to go ahead and evaluate and see if it's right for them so that they don't miss out. But I don't think it's for everyone. I really don't. But it is right for some people.
Absolutely. Let's segue over to that window, that timing, that perfect timing, if there is such a thing. I mean, I know you've been saying the 10 years, that's what they say, but you prefer the 5 years, the earlier the better. Just talk about that. So, and then how long should women stay on HT, and can you stay on it forever? Should you stay on it? Like, what's the current thinking?
And that's a question that I get a lot. And the question is a really, really good one, which was, okay, once I'm on, how long do I stay on?
Right.
We have 20-year data from the WHI, but what do we do? I happen to have many patients who have been on for, over 20 years. But I don't know the answer. I don't know the right answer. I don't think anyone knows the right answer. I think that this is something that we have to reevaluate every year. There's certainly no answer of when you must come off. And I think it's also different whether you're taking estrogen plus progesterone and you have a uterus, or you just have estrogen. As we get older, as everyone gets older, there are risks that increase. For instance, our risk of having a blood clot increases. So if you're taking something that also increases your risk of having a blood clot, now we're just magnifying this. So, certainly over the age of 80, 85, I would have some caution. But that's where the dose can also have a role, is we can lower the dose and we can decrease. We can also switch over to, for people who are taking medication by mouth, they could start taking it as a patch or as a gel, lowering the dose. But I think evaluating every year is reasonable. And sometimes there are indications where we have to go off. Someone may develop breast cancer.
Right.
Not necessarily from the treatment, but possibly the incidence of, right now, breast cancer is really very common. And the incidence of breast cancer increases as we get older. 1 in 8 women will develop breast cancer throughout our lifetime. That is a lot of breast cancer.
Yes.
So, of course, we always talk about all the healthy things we can try to do: decrease weight, get exercise, eat well, but it's a high number. So if someone does develop breast cancer and they are on hormone therapy, they have to come off hormone therapy.
Right. Right.
So the answer to that was a really long roundabout way of saying that there's no set answer on how long to be on. Certainly,
So again, evaluate every year.
evaluate every year, but the symptoms usually get better by about 5 years. So maybe around 5 years, someone might want to try weaning down in the dose, although I have no good data to say that you have to do that.
I'm curious too, is there data about, let's say someone starts 2 years after the onset of menopause, stays on until maybe 65 or 70, like maybe 10, 15, maybe 20 years. And then they decide to stop together, with their healthcare provider. They ease out and stop completely. Is there still protection after they stop completely?
So
Meaning, like, really, I'm
right,
thinking for bones, bone
bones,
loss, heart health, brain
right,
health.
right. So the heart health and the brain health seem to, yes, be lasting, that you do get benefit even when you're off. So that's a good thing for certainly. It may be that we've brought to a new set point. So you may have 20 years of estrogen, and now when you're coming off, it's going to take another 20 years before we're going to see any detriment. So maybe we just brought people into their hundreds. But there are some factors that don't continue after you stop taking it. So for instance, the insulin, when you're not on it, it's just as though you were going through menopause again, right? You have
Okay.
that increase. But hopefully you're a healthier self than you would have been. And for bones, we've prolonged the bone density. So hopefully, even if there is a decline, if you're declining from age 80 instead of age 50, that gives you a lot of extra years of better bone.
Yeah. Yeah. Again, it's a regret that I didn't have that big
But you know what?
discussion
But the flip of it is you did really well without it. And
without it
that's
so far.
another message, which is that it is not for everyone. And fortunately, we have other ways of being able to treat a lot of these symptoms. So for bone density, if someone does get to a level where their bones are not only with bone loss, but even in osteoporosis, where we're really worried about a fracture, we have a lot of good medications around, not just exercise and vitamin D, but also medications to build that bone back up.
Yes.
And
And prevent further
so,
bone loss.
right, right. And so living your healthiest self, there are a lot of ways to go about it. This is just one way, which may be helpful. And I think, especially for someone that has symptoms, I think that if you're having hot flushes, then just like you said, treating the hot flushes really makes sense to me. If you're having tremendous memory loss and can't think of the name or nouns, having estrogen on board for whatever period of time can be so helpful. And sleep, to be able to get through a night's sleep, can be just amazing. And so I think,
Absolutely.
not to deprive yourself if it's something that really would be right for you.
I kind of use sleep and hot flashes in the same little box, in the sense that forever experts thought, oh, sleep, not a lot's happening. You kind of
Right.
get knocked out and then you wake up and then go about your day. And of course, now we know that's not true at all, that so much is happening when we're sleeping. And that's why there's sleep is such a priority, a health priority now. And I feel that's true of hot flashes as well.
Right.
I think for so
You're right.
long, people just say, all right, you're going to sweat it out a little bit. You'll have night sweats and you'll kind of get through it. And that's the end of that. And once you're through it, you're through it.
Right.
And now we know that's not necessarily the case.
Right.
In general, I think women's health really has been just overlooked in so many ways, underfunded, overlooked, confusion. We need to put more money into research for women's health, for sure, going forward for the next generation of women. I have a question about, your peers. Now, we know about the WHI study that came out in 2002, and it created all kinds of havoc, and doctors stopped prescribing it.
Right.
Women stop taking it,
Right.
doctors stop
Right.
prescribing it.
Right.
And we know where you stand on this. Do you feel that 20 years later, would you say the majority of your peers in the healthcare community are with you on this? Or are they still confused too?
So I think that there is still some reluctance,
Mm-hmm.
even with new data and with new information and studies that are coming out looking at the effects of estrogen, that we talked about already, favorable and the risks. I think that there are still people who are very reluctant to use estrogen. And estrogen can be prescribed by any field, and it can be prescribed by internists, rheumatologists use it, OBGYNs use it, reproductive endocrinologists use it. So their endocrinologists are big factors in prescriptions for hormone therapy.
Mm-hmm.
So many different fields use it, and I think that in right now, I think there's a lot more attention on estrogen and hormone therapy than there certainly was even 5 years ago. I feel like there's just a lot more conversation going on and awareness that's happening than than previously. But you're right, I do think that it's a still evolving field, but it has definitely made strides.
Mm-hmm.
Um,
And you're right. There's been a lot more discussion out
mhm.
there among women. A lot of celebrities are hopping into this space, talking about it, coming up with
Right,
products for,
right.
to address certain menopause symptoms, and that's like helping to just foster the conversation. And I think that
Yeah,
hopefully women are going into their healthcare provider offices and saying, "Hey, I want to talk to you about
right,
this. I want to
right,
talk to you
right.
about
I think
HT."
I think I think people in general are just more comfortable talking about it. I know that I feel more comfortable because I feel other people feel more comfortable. Just in a social situation, I will admit, "Ugh, I'm having a terrible hot flush," or I am, I can't think of that word. It's a menopausal whatever. People know the name. They hear menopause. They hear it on shows. They hear it on sitcoms. It's just it's a more
It's in the
familiar.
cultural
It
kind of
is.
discussion
It
now.
is.
You're
It's more
absolutely right.
accepted. It's more accepted than it used to be, and it will continue to be as the um, as our yes, as our community becomes more comfortable.
Yep.
Leave
Okay,
it at that.
we we covered so much just now. This was a
We did.
master class in hormone therapy, Dr.
Yes, I think
Margaret.
so.
Truly a master class with the most up-to-date information. Thank you so much for that. Do you have a few takeaways you'd like to leave with the audience? I mean, we covered so
Well,
much. We want a few things to
I,
make
I
sure they remember.
I do. I mean, I think we summarized as we went through, but I think the main point is that one, um, no two people are the same. No two people have the same receptors in their body, the same metabolism, the same metabolic rate, the same way that they receive and but particularly medications. So what's right for you might not be right for your best friend or your sister. So individualized care is essential. My other main point is that for hormone therapy, there's a window of opportunity. And that window of opportunity is from the time that you hit menopause until 10 years, although I would say about 5 years.
Hmm.
And so, since there is that window, that this is a good time to explore and see if this is the right thing for you. My last point is that estrogen can be really beneficial for many symptoms, and it can be delivered very safely for many people. Not for everyone, but for many people. And so, if you are having symptoms and you don't have contraindications, that it might be for you for however many years. So, get help if you need it. And
Always so good to talk to you. And everyone, there will be links, as I said before, in the show notes, but also stay tuned for next week's episode when Dr. Margaret is coming back again to talk about vaginal health. Very important.
Such an important,
Yep, it sure is.
important
So we'll
topic.
we'll be talking
Can't
again
wait
soon.
to talk soon.
Okay, thanks.
All right.